Hi everyone, welcome to Global Academy of Medical Education. In this session, let us see what are all the questions that were asked in your FMG July 2023 examination. So welcome to FMG Pharmacology July 2023 recall. Myself Dr. Padmanabha TS, Faculty of Pharmacology at Global Academy of Medical Education. Hope all of you would have done very well in your exams, and if you are not done well also, please don't get tensed or worried. So if you lose one question also, you're not going to lose anything. So probably you would have done very well in other MCQs as well. So let us discuss the questions which were asked. So these are just a disclaimer is these are the questions that were based on the recall basis. We have gathered it from various platforms. So the question may differ with respect to the exact question that were asked in your examination. So later days we'll try to find out the exact question in the options. Thereby you're going to get a exact answers. So the questions which we got was the drug which was used in facial palsy. So which is the drug which is used in facial palsy? So they had given the option of acyclovir, ceftriaxone, prednisolone and naproxen. So naproxen is a non-steroidal anti-inflammatory agent. This is a non-steroidal anti-inflammatory agent, and this is the corticosteroids, and you have got the ceftriaxone. Ceftriaxone is the cephalosporins, whereas the acyclovir is the antiviral drug. So although the facial palsy, the most common will be the Bell's palsy. So Bell's palsy is the common palsy which will be occurring in the face. So the drugs which is very useful in the case of facial palsy is, can you guess it? Yes. So thinking that since herpes is the most common virus which causes the Bell's palsy, you may be thinking that acyclovir will be the answer. So but here acyclovir is not the answer. It's not effective in the treatment of facial palsy. So what could be the best option or preferred drug? So the preferred drug is, here is the right, is the prednisolone. So the answer is prednisolone. So prednisolone is preferred in case of the facial palsy. So let us see the description. So this is taken from the Harrison 20th edition, page number 3170. So it states that, you can see here, the course of glucocorticoids will be given as prednisolone 60 to 80 milligram daily, and it will be given during the first 5 days, the dose of 60 to 80 milligram, and then the dose of prednisolone will be tapered over the next 5 days, and this will going to shorten the recovery period, as well as it going to improve the outcome of the patient. So why we are emphasizing that prednisolone is the answer? There are clinical trials which has been done, and they have found out that the prednisolone has got more beneficial effect in terms of functional outcome when compared to the antiviral drugs like acyclovir and the valacyclovir. Let's read out the next paragraph. So although the large and well controlled random trials found that there is no added benefit with respect to the antiviral agents like acyclovir and the acyclovir, that was given 5 times a day daily for 10 days compared to glucocorticosteroids alone. So that means what they are saying that glucocorticoids are more beneficial than the antiviral drugs. So here the glucocorticosteroid which is preferred will be the prednisolone. So prednisolone will be the drug which is preferred in the facial palsy. So earlier they have also done a study regarding the combination therapy. So combination therapy with prednisolone and valcyclovir might be marginally better than prednisolone alone, especially in case of severe clinical presentation. But otherwise, unless it is severe, so always it is the prednisolone which is more beneficial than the antiviral drugs in the facial palsy. So what will be the option here? So you cannot go with the naproxen. Antibiotic also it's ruled out. Acyclovir also ruled out. So the best option here is the prednisolone. So prednisolone is the correct answer here. Okay, next. So as you can see here, the most common infectious agent which is causing the facial palsy is your herpes simplex virus type 1 and the varicella zoster virus. So herpes simplex virus type 1 will cause Bell's palsy, again an important question that can be asked in your medicine, and varicella zoster virus will going to cause your Ramsay-Hunt syndrome. And these are some of the other symptomatic measures you need to take while treating the Bell's palsy or facial palsy, that is the use of proper paper tape to depress the upper eyelid during the sleep to prevent the corneal damage due to drying, and artificial tears has to be instilled to prevent the dryness of the eye, and also the massage of the weakened muscle. And please remember, Bell's palsy or facial palsy, it is your prednisolone is the answer, not the antiviral drug. So next, coming to the second question, that is the benzodiazepine antidote is. So they had asked 4 options like atropine, B is physostigmine, C is flumazanil, and D is naloxone. So what will be your answer here? So what is the which is the antidote for benzodiazepine poisoning? It is the benzodiazepine poisoning antidote. Poisoning or overdose. So it is a direct question, very easy. You need to find out the antidote. So atropine will be the antidote for, so let us understand, atropine will be the antidote for organophosphate compound poisonings. So where do you use physostigmine? Physostigmine, again it is used as an antidote in case of atropine overdose. What about the naloxone? Naloxone is the opioid poisoning or in overdose. It is opioid receptor antagonist. So what will be the right answer here? So flumazanil is the benzodiazepine receptor antagonist, and it will be the antidote for benzodiazepine overdose. The right answer will be your flumazanil. So always I tell, do not confuse flumazanil with the fomepizole. So where do we use fomepizole? Fomepizole is a alcohol dehydrogenase inhibitor, which is useful in the treatment of the methanol poisoning methanol poisoning, as well as in the ethylene glycol poisoning in case of the methanol and ethylene glycol. So it will be very useful. Do not confuse. So fomepizole is alcohol dehydrogenase inhibitor, whereas the flumazanil will be your benzodiazepine receptor antagonist. So next, moving on to the next question that was asked. Okay, there was a chronic alcoholic patient presents with the loss of coordination, confusion, unsteady in the gait. So which vitamin deficiency is most likely seen in this patient? So always remember, whenever we talk about the alcoholics, always there will be a vitamin deficiency, especially you will have a thiamine deficiency. So thiamine deficiency will be there. So what is the other name for thiamine deficiency? So the other name for thiamine deficiency is, it is your vitamin B1. So the right answer will be your vitamin B1. So it is a classical presentation of a chronic alcoholic patient who is going for vernix encephalopathy. So whenever there is a vernix encephalopathy, we are going to give a thiamine injection. So let's see the description. So whenever there is a chronic alcoholic, and here there is a chronic alcoholic, though the chronic alcoholic, the manifestation can be acute also because of the binge consumption of the alcohol, which will going to lead to the deficiency, and it is going for vernix encephalopathy based on the symptoms. So if there is an acute alcohol intoxication, you can go for thiamine 100 milligram per day parenterally, So remember, so thiamine will be the vitamin B1. So again, very important question. So thiamine is added to each vat of glucose solution infused. So please remember, most of the neurological symptoms in chronic alcoholism will be due to this thiamine deficiency. So thiamine deficiency can lead to peripheral neuritis, vernix encephalopathy, and Korsakoff psychosis. So you need to give thiamine, that is vitamin B1, or it is also called as anurin. So whenever this alcohol use disorder is present, the complication what you can expect is, along with vitamin or thiamine deficiency, you will also expect the alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, and testicular atrophy. So why we are discussing about the complication means, so this can be a potential MCQs as well as it can come as the case based or clinical scenario. So you need to understand all those things like complications, so you can correlate with the condition and you can come out with the best answer. So what will be the treatment for alcohol use disorder? So usually you give naltrexone, which is an opioid. Again, naltrexone is a opioid receptor antagonist. So it is given to reduce the craving. Again, a very important question, MCQ question. So it needs to be avoided if there is a hepatic or liver failure. Hepatic insufficiency is a contraindication, or you need to avoid using the naltrexone. You can use acamprost, which is contraindicated in case of renal failure. If the patient has got renal failure, you need to avoid giving the acamprost. And you can give disulfiram. So this is a drug which will going to cause abstinence from the alcohol use. it is regarded as the disulfiram is regarded as disulfiram is regarded as the aversion therapy. Aversion therapy. So disulfiram is a acetaldehyde dehydrogenase. It inhibits the acetaldehyde dehydrogenase. Whereas fomepizole will going to inhibit the alcohol dehydrogenase. Disulfiram being aversion therapy, it will going to inhibit the acetaldehyde dehydrogenase. Thereby, what will happen to the acetaldehyde? Acetaldehyde concentration will increase, and it will leads to the what it will leads? It leads to the symptoms like tachycardia, chest pain, tremors, etc. if alcohol is consumed. If the alcohol is consumed again, so acetaldehyde concentration will increase. That will leads to the disulfiram like reaction. So these are called the disulfiram like reactions. So in Wernicke-Korsakoff syndrome also, if they ask about Wernicke-Korsakoff syndrome, so the drug will be your vitamin B, that is your thiamine. Thiamine should be given to prevent the vitamin deficiency and the consequent manifestation, like as you saw, like here neuritis, Wernicke encephalopathy and Korsakoff psychosis. So even in your exams they will going to ask what is the triad of your Wernicke-Korsakoff syndrome. So the triad will be, what will be the triad? Triad is of CoA. One is for confusion, ophthalmoplegia and ataxia. So if it is not treated, what happens means it may progress to irreversible loss of memory, confabulation, personality changes, that is Korsakoff syndrome. So treatment for the Wernicke-Korsakoff will be your IV vitamin B1. So there is one more tricky question that can be asked in your exams in the subsequent years, that is the vitamin B1 has to be given before dextrose, not after the dextrose. So what is the reason? So again this will be the potential MCQ. So vitamin B1 has to be given before dextrose, not after the dextrose. So the reason is, let us find out the reason. So in Wernicke encephalopathy in alcoholic patient, given glucose, what will happen? So already you have a thiamine deficiency. Instead of supplementing the thiamine deficiency, if you give a glucose before the thiamine, so what will happen? Thiamine deficiency will impair the glucose breakdown and it will going to cause ATP depletion. So this will be worsened by the glucose infusion. So this is a very important question. So what will happen if you give a glucose before the thiamine? Thiamine deficiency will going to impair the glucose breakdown as well as ATP depletion. This will be worsened if you give a glucose before thiamine. So in patient with chronic alcohol overuse or malnutrition, so please give thiamine before the dextrose to decrease the risk of precipitating Wernicke's encephalopathy. Very, very important. This can be your potential MCQ, whether thiamine is given before or after the dextrose. So thiamine is given before the dextrose. So next question was asked was regarding the conservative management or conservative regimen in the treatment of appendicitis. So I could not find out the option. So for conservative management of the appendicitis, you can go with a broad spectrum antimicrobial agent, broad spectrum antimicrobial agent. So this is the exact lines which were there in the Harrison. So the all patient should be fully prepared for surgery and have any fluid and electrolyte abnormality has to be corrected. So first you need to correct the electrolyte deficiency if there are any existing, and later either you can go for laparoscopic or open appendectomy, which is a satisfactory choice of option in case of uncomplicated appendicitis. So it will be a minimal invasive procedure. So management of those patient with let us see here carefully, mass representing a phalgomen or abscess can be more difficult. So the surgical procedure in a patient who has a mass representing the abscess, it will be more difficult. In such patient, the treatment will be here. You start on the broad spectrum antimicrobial agent, and drain the abscess if the abscess is more than 3 centimeter in diameter, and you need to give a parenteral fluids as well as bowel rest if they appear to respond to the conservative treatment. So once you start on the antimicrobial agent, and if the abscess is more than 3 centimeters, you need to drain it and you need to go with the parenteral fluids, and bowel rest has to be given as a part of the conservative management if it is responding. So then the appendix can more safely be removed 6 to 12 weeks later. So why you need to remove the appendicitis after 6 weeks or 12 weeks of the broad spectrum antimicrobial agent? The reason being the inflammation would have been come down. That is the basic concept why you need to give a broad spectrum antimicrobial agent in case of the mass representing the abscess. So it will be a broad spectrum antimicrobial agent to treat the conservative way in the treatment of appendicitis. So once the inflammation has come down, you can go with the as usual procedure. So next, coming to the next question that was asked regarding the Offman degradation, or it is also called as Offman elimination. So which is the drug which undergoes Offman elimination? So please remember, Offman's elimination is with respect to the atracurium. This is the skeletal muscle relaxant which undergoes non-enzymatic degradation. So the meaning is it undergoes non-enzymatic degradation. Very, very important. Or inactivation, non-enzyme inactivation. So let us see. So Offman's elimination is nothing but it is an inactivation of the drug in the body fluids by spontaneous molecular rearrangement without involving any enzymes. So it is a spontaneous inactivation. So without the enzyme, spontaneous inactivation without the enzyme. So please remember, atracurium undergoes the Offman's elimination. So there are other questions that can be asked in your subsequent examination regarding the atracurium. So atracurium, when compared to cisatracurium, it's congener cisatracurium. So it will cause histamine release. So one of the side effects which can lead to decrease in the blood pressure as well as the allergic reactions. So histamine release can also be seen with other skeletal muscle relaxants like mivacurium and ditubocurarin. So one of the metabolite which is produced by the atracurium which can cause the side effects is the responsible for side effect is the laudanosine, which will not be seen with the cisatracurium. So with the release of the laudanosine metabolite, the muscle relaxation is potentiated by the inhaled anesthetic as well as the aminoglycosides and also by the quinidine. So basically atracurium is a non-depolarizing neuromuscular blockers. That means they are the competitive NM nicotinic receptor antagonist. So what are the other examples for non-depolarizing neuromuscular blockers? You have a cisatracurium, pancurium, rocurium and vecurium. Another very potential MCQ which can expect in the further December 2023 Fmge is here. How do you going to reverse the atracurium or non-depolarizing neuromuscular blocking drugs. You can use a neostigmine, which is the cholinesterase inhibitor, or you can go with the sugammadex. Sugammadex is specifically for rocuronium and vecuronium. So otherwise, if you find cholinesterase inhibitor neostigmine, you can go with the neostigmine, or if they had given sugammadex, you can go for sugammadex. So along, whenever you are giving the cholinesterase inhibitors like neostigmine. So what are neostigmines? Basically, they are the anti-cholinesterases. Basically, they are going to increase the acetylcholine levels. So this will going to act on NM receptor as well as muscarinic receptors. NM as well as the muscarinic receptor. By acting on NM, it will going to cause recovery of muscle tone. So since it also acts on the muscarinic receptors, what will happen is it will going to stimulate and will to cause muscarinic related side effects. To overcome this, what you need to give is you need to give a atropine, which is anti-cholinesterase. So anticholinergics like atropine should be given to prevent the muscarinic side effects. Whenever you give a neostigmine. Is it clear? Okay, fine. Next, coming to the next question that was asked. So which is the drug which was used in the treatment of mountain sickness? So the mountain sickness, you'll give the drug called astazolamide, which is a carbonic anhydrase inhibitor, which is a diuretic in nature. Usually act on the proximal convoluted tubule, and what it causes, it will going to cause sodium bicarbonate loss. Whenever there is a sodium bicarbonate loss, what it will lead to? It will lead to metabolic acidosis. So astazolamide is used in the treatment of mountain sickness. So let us see how astazolamide will going to help in the treatment of mountain sickness. So in exams, they would have given the case history like the patient was climbing the high altitude, rapid ascent of the high altitude, and symptoms appeared like headache, nausea, giddiness, weakness, and insomnia was present, which was lasting for 1 to 2 days. And few subjects may also develop acute sickness due to production of pulmonary and cerebral edema. So this can be a part of your case based or scenario based or the next level based MCQs. So you need to, when do we start to prevent the mountain sickness? So you need to give the acetazolamide. For prophylaxis as well as the symptomatic relief. So when do we need to give the astazolamide? Astazolamide has to be given 1 to 2 days before the travel. So what is the mechanism by which astazolamide will going to prevent the development of mountain sickness like the headache, giddiness, nausea, weakness, insomnia? So probably it works by altering the carbon dioxide transport in the lung tissue and the brain and decreases the formation of CSF, and also it lowers its pH. So as we discussed, astazolamide is a carbonic anhydrase inhibitor. Again, this can be your potential MCQs. How it going to act? It acts on the proximal convoluted tubule. What happens to the bicarbonate? There will be the bicarbonate loss, bicarbonate depletion that will lead to metabolic acidosis. Apart from mountain sickness, they are also used in the treatment of glaucoma. So basically, astazolamide is given in the form of the topical route in the treatment of glaucoma, that is dorzolamide and the brinzolamide. So what are the toxicity which you can expect when you give a astazolamide? You can expect paresthesis. This is the paresthesis or paresthesias, and hepatic encephalopathy due to the metabolic acidosis. So next, coming to the next question, that is the vitamin A. So in endemic area, what will be the dose of vitamin A for 1 to, probably it can be of 1 to 3 or 1 to 6 year old child, 1 to 6 year old child, or a to 6 year old children's. So the option were uh, 2 lakh unit orally for 6 months, 1 lakh international unit orally for 6 months, 2 lakh unit international unit orally for 6 weeks, and 2 lakh international unit orally for 1 week. So here the right option will be here. The best option is, it is here, 2 lakhs international unit orally for 6 months. So let us see why this is the answer. So here you can see that vitamin A for a 1 to 6 year old. So prophylaxis, they could have given prophylaxis here, prophylaxis, or a prophylactic dose. So up to 9 months. So what will be the dose? 1 ml. That means 1 ml will be equal to 1 lakh international unit. After 9 months, every 6 months till 5 years, it will be of 2 ml, that is 2 lakhs international per unit, 2 lakhs international per unit. So 1 to 6 years, so till 9 months, so till 9 months, what you should give? You should give 1 ml, or it is 1 lakh international unit. So from 9 months onwards, 9 months onwards, 9 months onwards, from above 9 month till 5 years, till 5 years, that to every 6 months, what you need to give? You need to go for 2 ml, or it is 2 lakh international unit, 2 lakhs. So 2 lakhs international unit, or that has to be given, which is the route? Given through oral route. So orally for 6 months, So this was about the some of the MCQs that we could get it from the students as well as from the other platforms. So if you have any more questions that were pertain towards the pharmacology as well as the drugs, or any drug interaction, or anything with respect to the treatment, drug of choice, please share your questions and thoughts on the questions that were asked in your exams. You can comment it in the chat box or the comment box, so that we can come out with the specific answers. Or since you will get the topics, so it will be like a ready-made thing which you need to study for the forthcoming exams, because once the new topic are asked, the same topic may be repeated many times in the subsequent exams in a different format, as well as the question will revolve around the topic. So the basic thing is, the question and option may not be repeated in the exact manner, but the same topic or concept can be asked in your subsequent exams. So likewise, this time they have asked about the astazolamide for mountain sickness. So next time they may ask, what is the other use of astazolamide? What is the non-diuretic use of astazolamide? So then you can go for the glaucoma. So likewise, there can be many answers. The one of the best frequently asked question is the antidotes. So now they have asked for antidote for benzodiazepine overdose. Probably in the next upcoming, they may ask for antidote for other drugs also, like antidote for heparin, antidote for warfarin. Warfarin will be your vitamin K, and heparin will be your protamine sulfate. So likewise, there can be many questions that will be repeated, not exactly, but in the various format. So what we can sense from this FMG is, they have not asked a direct questions. They are checking about your thinking and concept based acquisition of the information, and probably this type of questions which you have got now, probably it is a beginning of the questions that you can expect for in your next exams if it happens next exams. So they are making tough and tough, not to worry, but only thing you should keep in mind is you need to repeatedly do the previous year MCQs. Why PYQs are important? To find out the topics that can be asked in your subsequent exams. Not the same MCQ, I'm repeating, not the same MCQ, but you can concentrate on the topics which has been asked and you can expect the related questions in your subsequent exams. So hope all of you would have done well. Again, we'll come out with the one more video on the recall session on pharmacology once we get a proper question in the MCQs. Till that time, have a nice day and do not forget to share and hit the like button for more updates on pharmacology, and do subscribe for GAMEPG app on YouTube. Thank you.